this first session this afternoon will be on preparing those clinicians, right? How do you get that message out to them? This is coming. How do you, as physician champions, continue to help with your peers and let them know that they're getting ready to see this change happen? So, Tom?
Oh, okay.
All you.
So, you guys are all now postprandial hypoglycemic.
Yes.
Okay, so I just am asking, if you decide to sleep, try to scooch down your seat so you don't snore. And okay, what we're going to do, this is typically the way we do these, is I do the first presentation on macro, which is the what, and then this is the presentation we do immediately after that, which is kind of a how. And then we do some table talk stuff, and then the patient and family engagement talk comes later in the day. So what we're doing is we're kind of catching up now. What I'm going to do is kind of smush together this presentation and the data presentation. Now this is going to be, I got to tell you, this presentation is going to go stratospheric, strategic, and then sometimes down into the weeds as well. But this is what you've had so far has been a lot of fluffy theoretical. Yes, they're changing our payment. Yes, I'm scared to death. Yes, I don't understand it. Yes, I still have to go back and communicate this. And I understand that now I've got to change the way my clinic operations actually operate. And kind of the other thing I would kind of leave you with is, I think you're getting that the TCPI project is going to be about. It's not just generating data, but it's generating data that then we use to fuel local performance improvement transformation. We're gonna have to do it different. We're gonna have to block and tackle differently. And I think most providers get the concept that we're moving from a volume-based system to a value-based system. And I'm gonna kind of talk a little bit about that. But first of all, we have the Compass PTN, which we've all talked about, and we're going to kind of be together, and we're going to figure out how we move this thing together over 4 years. How do you do that? I mean, you got all these states, and we're a separate state, and we don't even talk to each other most of the time. So how do we bring this stuff together? So if you're not familiar, I want to make you aware, next slide, of the
sorry, you got a rookie here now.
No.
There.
Thanks. So objectives for this talk, we're going to talk a bit about requests and offers at the end here. I'm going to describe the Compass PTN resources and structure, and I'm going to go through the modified breakthrough series model in our TCBI timeline. So next slide. This is not like a nuclear reactor thing or anything. This is the modified breakthrough series model. This is how you do organizational change. This is roughly, we're going to use a modified version of this for our learning community. Okay. Now I don't want you to look. By the way, I said this yesterday. I get seasonal allergies. So when I start coughing, I'll start coughing because I'm talking too fast, or I'll kind of trigger my cough reflex. I'm just telling you that so you don't think of some kind of an infectious disease or something. Okay. But the modified breakthrough series model is really a basic roadmap of how we're going to go forward. Okay. So think of it this way. This is designed by the Institute for Healthcare Improvement. This is not a formal community, a formal collaborative like we're trying to identify new knowledge and change. This is going to be our organizational framework on how we're going to meet together and do work. So we select the topic and select the space. We got to figure out how we're tied. So we're basically for that first rung on the ladder, we're going to try to get ready in value-based reimbursement. Start to move up into those advanced payment methodologies. That's what we're doing. You enroll participants. We've tried to enroll 500. We've got more than that, and I think we're going to have more than that yet as we go forward. But you bring them together into a learning session. This is learning session 1. We're going to have one learning session per year. There will be other places that we will touch base, but there will be another one of these next year, and I expect it's going to be about 100 people because you're all going to be bringing other people. The learning session, we all come together, and what you do is you get all kinds of information, you bring it together, you kind of stop with this learning session, and you work in an about you. You're going to go home and you're going to work, and then it just recognizes that there are PSA cycles, that we're doing serial PSA cycles in our site. We go home, and then action period, and we'll come together again. And basically, it's going to be, it's described as a learning community. We are a community, but we're going to be continually evolving, sharing, and moving things forward. So we're kind of okay with that. Kind of get what we're doing. Are you guys Randy? Okay. Yeah. Okay. So next slide. Okay. We're moving from volume to value. Okay. You don't know what you're doing. We don't know what we're doing. This is like fishing in football, and we're showing up. Everything about our DNA is fishing, and now we're coming together, and we've brought everybody together, and now we've got to run plays. We're going to get measured in different ways. We're going to have to act in different ways. Most fishermen aren't running around a lot, guys. They aren't hitting people, that's for sure, and they've got additional equipment. Okay, we're going to have to figure out how to do a whole different deal. So the point I want to make is many of you, like when you talk to your docs and you talk to them about value-based care, they're going to go, yeah, I got that. We don't know, and we don't know because we don't know what we don't know. So what I want to do is I'm going to just stretch your brains here for a little bit. This is how we're going to work together, okay? Next slide. There's two kinds of knowledge that and knowledge how. Like knowledge that is like, you know their bicycle has two wheels and a seat and handlebars and a foot pedal crank, but that stands in sharp contrast to the skill and the knowledge of knowing how to ride a bike, okay? That's kind of where we are right now. We know what value-based healthcare looks like. We know components of it. We do not know all of the components of it. But our ability right now to coordinate our legs and our arms and our balance mechanisms and all that stuff right now to ride the bike ain't so hot, okay? Just understanding we have to learn how to ride the bike, right? Now the whole point is this isn't just about learning to ride the bike because they tied reimbursement to it, okay? So next slide. It's going to be more like this. We've got to not only learn how to ride the bike, we have to learn to excel at it. We're going to have to go farther and faster. We're going to have to have special equipment. We're going to have a special course as we do, but this is a new sport. We're going to have to figure out how we do this. Now, you currently operate in systems. And when I talk about a system, I'm not talking about your healthcare system. Your clinic is a system. Your office is a system. You are in a complex, adaptive system. Complex because of lots of moving parts, adaptive because, hey, how's that working for you? Let's see if we can change this and do different things. We have brains. We figure out how we adapt to different things. But we're in a system. Systems are designed to achieve certain aims. Systems, so you pull the system together, and then the system will create aims that it's trying to do, and then it will apply the resources of the system to do those things. So systems create aims, and aims create results. That's kind of how we operate today. Anybody disagree with that? So what happens, next slide. So this is kind of how we operate. If we need to improve the value of what we've got, over time, we need to improve the value, so we kind of mark it out, we need to get better. The problem is we can't, because why? We don't have enough resources. What's the first thing everybody says? Well, if they pay me to do that, or they don't pay me to do that, then we can't do it. So we can squeeze a little bit of improvement out by being more efficient, or working harder, or being more sincere. When we do that's a big deal. We're taking it seriously now. How many of you don't take your job seriously, right? But that's, we just right now we improve what we're doing within the current system by either putting additional resources into it or working harder. Reminds me of the volume-based treadmill. Here we are. Just turn it a little faster, a little faster, a little faster. Just before your ST segments went up and you had a heart attack, right? Okay. So the whole point is that ain't going to work because we can't print any more money. We don't have any more money. So the whole point is, how do we do this? How are we going to do it? Well, kind of the father of performance improvement is a guy named Dr. Dr. Deming, who was in the 60s, he basically he was kind of the godfather of all this quality improvement stuff. And he came up with a different quote. Next slide. He made the point, systems don't create aims. Aims actually create the systems. We operate currently within systems that have been designed to meet care needs for our communities based on a certain reimbursement system currently. We operate within an existing system. Existing systems tend to protect themselves. Existing systems don't want to change. Existing systems have turf. And we have got to break the existing system. How do you break the system? You don't set aims for the system. You basically set new aims and have new systems develop around those. We have got to develop new systems of care. We've talked about community engagement. We've talked about patient and family engagement. Those are all design principles of the new system. So systems don't create aims. Aims actually create the systems. You with me so far? Okay, so next slide. Now that sounds interesting, Tom. How are you going to do that? Because you're telling me that I got to improve the value now from here to way up here, and you're telling me I can't put any more resources in it. And so how are you going to do that? And the answer is we don't have the knowledge. We're going to have to build the knowledge. We're going to have to build the systems. Next slide. So what happens is you get together all the people that are within, we're all working to achieve the new aim, and now we work together, we share, we work together to kind of create new knowledge to get to that new point. It's building a new path. The jagged line basically reflects the fact that sometimes you're going to have some challenges, but you've got to build a new path to get there. Now, you look at this and you go, okay, that's a really nice kind of fluffy sociologic application. That's never, in fact, anybody who's done anything particularly difficult has ever really bought this thing and did it, right? Okay, next slide. You ever seen this guy? Okay. In 1961, the United States said, April of 1961, we're going to put a man on the moon by the end of this decade. Now, and everybody's familiar that President Kennedy made that declaration. And that's an example of an aim, but we had no system. We had nothing around that. Matter of fact, when you think about what was going on in 1961, there were only two countries that actually had a space program, the United States and Russia. And of those two, we were behind. The Russians had Sputnik. Sputnik was about this big. Okay, it's a satellite about this big, had 4 antennas sticking off of it, and it was circling the Earth. They had shot something up that was in orbit. Okay, and what was happening in the United States, there was actually a lot of consternation. People were kind of freaked, like the Russians are going to start dropping things on us, or they're way ahead of us. In the United States, what happened with the United States? Our rockets blew up. We had about a 42% blow-up rate with our rockets at that point. So when President Kennedy did this, he didn't do it from a position of strength. The other thing he didn't do is he didn't do it from a position of a lot of resources, because NASA existed, but NASA was about 4 years old, the National Aeronautics and Space Administration, but it was basically about building planes that could go into the stratosphere. The X-15, some of those rocket planes, that was what was in that period, but that was all we had. We didn't have anything else. So with that, Kennedy couldn't just call up NASA and say, hey, roll Saturn V out and put it on the pad and let's go to the moon. They had to start building the systems. Well, they started with the Mercury program, and some of you may remember that, but the Mercury program said we're going to put one guy in space at a time. They pulled out an old missile that they used to launch bombs on. It was called a Redstone, and they put Alan Shepard on it, and they had to stabilize the system as much to be able to launch him, and they launched Alan Shepard into space. Anybody remember exactly what happened with Alan Shepard? There's two things about Alan Shepard that are important. One of them is Alan Shepard went up and then came down about 35 miles from Florida, and they were able to fish him out and fish the capsule out, and it was a success. So one thing is he was our first American that we sent into space. The second thing you know is he was the first American that was incontinent in space. And Alan Shepard was on they had so many delays on the pad that he basically had to get permission to wet himself before they launched in space. I'll just let you guys like to know that. So we completed one cycle. Success. We go to the next cycle. Gus Grissom. Okay, we're going to launch another guy. We launch him up. Then he comes out. Can we repeat it? We fished Gus Grissom out, but we couldn't fish out the capsule. We lost the capsule. So it was a partial failure. We had to learn. What do we do different? They had to figure out some different processes so that they could make sure that they didn't lose the capsule. Next one was, anybody remember? John Glenn. Everybody, John Glenn, like the name John Glenn. And you know what he did, but anybody know what John Glenn did? John Glenn was the first one that we put up, and he circled the Earth. He orbited 3 times, and then brought him in, and we saved the capsule, and he had a safe parade. What's her name? It was, anyway, we had 4 more flights on the Mercury program. Had to learn the next step. Okay? Next step, you guys. What's the big hallmark of Gemini? Open the door. They opened the door, and they would float outside, and they could come back in, close the door, and repressurize. And they did it successfully. Ed White was the first guy to do a spacewalk. Okay? And we did about 6 of those. And then we went to Apollo, and we're doing 3 guys. And we killed the first 3. We cooked them in a capsule on the launch pad. They had a fire. Failure. Jagged mark down. Okay? But they learned. And they continued to develop, and we went to the moon, and we learned how to pull the stuff out, and anyway, and basically finally landed on the moon in July of 1969. We made it. The point I want to make here is that this is an Ames-based initiative. It was huge. We had no clue how to do it. Do you see where we are? This is an Ames-based initiative. We have got to do something different. And interestingly, everything that we know is a barrier to what we have to do. NASA at that point, NASA almost lost the contract because they kept thinking they were going to have to build X-15s to go into space. And they had to let that go and come up with a whole new delivery system to be able to do this. Okay? We're going to have to figure out how we let go of things that we know now to build some of the new things, some Ames-based solutions going forward. Next slide. So the Ames will create our systems. I would pose to, and then our systems will create results, but I would pose to you, what are our aims? We've got to have a sustainable system. It has to meet the needs of our community. We're going to have ways of delivering the care that it's going to be the highest quality care. It's got to be safe. It's got to be effective. And I'm sure we're going to come up with other design principles as we go forward. You notice the one I didn't say there? We didn't say, we got a system right now where we got a lot of people used to flying X-15s, but we're going to have to figure out how we do this thing different. This isn't just about how much money did I make. It's about how much care do we deliver and how effective is that care. And then is it going to be sustainable as we go forward? Slide. So I hope you look at this a little bit differently now, because now what we've got to do is we've got to get together, take the best knowledge as we have this, failures, successes, come together. And when I say coming together, this is the first time we brought together the South Dakota kind of group. But this is the South Dakota group within the Compass PTN, and we have North Dakota, and we have Nebraska, and we have Iowa, and we have Kansas, and we have Oklahoma, and we have Georgia, and we are one PTN. There are 28 other PTNs of knowledge that are coming down the road, and this is that learning community of 140,000 dedicated to figure out how to build a system that will be sustainable. Next slide. Like that. Next slide. This is what we're trying to do. Again, this isn't just about getting measures. We're going to talk a lot about data. This isn't just about getting data. This is about using the data to change the way we deliver care locally. Remember, and we're going to talk some in this talk about, remember what the change package said. Marty touched on it. I'll say it again. Patient and family engagement, data performance improvement, sustainable operations. Okay? Those are the kinds of resources we're going to be breaking as we go forward. Next slide. So, Anybody ever heard of the Patient-Centered Medical Home? I know you have. Patient-Centered Medical Home has been around. You know, frankly, for many of you, you're kind of going, that sort of came around about 2007 and got real popular and then started to kind of lose some of its juice. And where are we here? Okay, that's kind of, most people think of it, it was real popular a while back, but wasn't it just a primary care ploy to try to get more money out of the volume-based healthcare system? That's kind of where we've been. What I want to do is tell you the story of medical home, and I also want to build the case with you that the skills of the medical home, the stuff that we have to do, that you talked about certification, those types of things take us about 40% of the way to where we need to go to get on the moon. But it's the first 40% that we have to do. It's got the components of patient and family engagement. It's got the components of data management. It's got the components of team-based care. It's got the components of access to care. It's got the components of sustainability through altered reimbursement. So it's just a good place to start. If you don't start anyplace else, start looking at the components and get driving medical home nests as you go forward. So let me just tell you about the medical home. This is not a new concept. It was actually established by the Academy of Pediatrics in 1967. The idea was we have these broken kids that just get referred from specialist to specialist to specialist. The pediatrics folks said, hey, shouldn't we have one place where we kind of coordinate the care? And it was a pediatrics concept, and it basically it kind of just stayed there until 2002. In 2002, there was all kinds of additional discussion in the industry, in our industry, about what else should we have in primary care? How shouldn't we be more comprehensive and complete? So there were new attributes that were added by the American Academy of Pediatrics in 2002. And frankly, it kind of got some other specialties kind of sniffing around this, like family medicine and internal medicine. Next slide. Marty had this slide up. This is the chronic care model. How many people have seen this besides this morning? How many people could describe this? Okay. You need to understand this is the key to value-based care. Okay, we've got to align the resources within our communities. And I'm just going to take a moment to back into this thing a little bit because it describes 4 different touch points. Ready for this? You may be clinics here. You've got to be able to manage the 4 different touch points. Wherever you are, you've got to be able to manage within that. So the 4 different touch points. If we're going to improve outcomes, we've got to have productive interactions with the people that need to be interacted with. So our patients, persons, whatever we call them, they've got to be engaged in a different way. They need to be informed and activated. Informed, I have diabetes. What does it mean to have diabetes? How do I manage my diabetes? What does that impact? How does that manage my family? All that stuff. They need to be informed, and they have to be motivated. How often do you hear your providers say, well, the patients should just pay attention? They're non-compliant. Those non-compliant patients, I personally have a personal theory that non-compliant patients, out of all my non-compliant patients, there's probably a segment here that actually are antisocial, but there's an awful lot of people that are disenfranchised from the system, or nobody's going to listen to it, or don't know, or are intimidated by the intelligence and the systems of our systems. They don't feel like they can. Non-compliant patients are less non-compliant and more disengaged. Okay? We need to create informed, activated, motivated patients. That's one touch point. The other thing is we have here a proactive practice team. Now, these folks, we've got to be a team, we've got to be prepared, and reactive. You realize our health system today is a read system. People come into you with a broken. You don't go and fix them because your job is to diagnose and treat. Right? We need to have a prepared and proactive system to manage some of the other factors. I mentioned the patient-centered medical home. A patient could say that's a patient-centered medical home, but there are other people in the team that need to be there. You know, frankly, we talked about chiropractors who can't and actually manage this stuff. Pharmacists are a huge opportunity. How do we engage pharmacists in a different way? They have more contact patients than we do. They pick up the prescriptions every month. Yes. behavioral health, perfect example. You talk about the other country, you know, there's a whole chunk of charges that are just because we're an ill-equipped healthcare system. That's another whole lecture. So we've got to have interactions to improve our outcomes, but it's done within this cloud of resources around us, and that cloud above us has the community, but then this subset of the community, which I would call the medical neighborhood, which includes your hospitals and your specialists and your long-term care and your pharmacists and all these healthcare resources that are care, but uncoordinated care. So, and then we have, again, the community, which is public health, area agencies on aging, all kinds of other community resources that are out there. Everybody's trying to do something, but it's like Brownian movement. It's just disconnected, okay? So what our opportunity here with the chronic care model is to take these 4 touch points, the community and the medical neighborhood and the medical home and the patients, and those are all places where we have to improve the way we operate. Does that kind of make sense? I apologize for the digression, but it really kind of sets up what I want to say here for the medical home. So if this is, and the chronic care model actually came out around 2002, 2003, I believe, with Ed Wagner. So it was really mind-boggling how it kind of changed some things and arranged our thinking. Next slide. So back to medical home. The pediatricians and the internal medicine folks and the primary care folks all started bringing these models together and said, we should be smushing this together into one list of stuff we ought to do. So there was the primary care model and the chronic care model, and we mushed these together into one standard model, and they came up with, next slide, the joint principles of the patient-centered medical home. Again, in 2007, these academies plus the osteopathic physicians came together and endorsed these 7 principles I'm going to show you. Now there's over 35 medical specialty organizations that endorse this concept. Next. So 6 pieces, okay? Actually, there's 7 characteristics, but I'm going to describe them in a different way. Personal position in an ongoing relationship. The only verbiage that they could get approved was a personal position in an ongoing relationship, and you'd imagine the internist, family physicians, pediatrics are the primary authors that are going to camp on a doc. But the fact of the matter is, there's practitioners, pediatricians, there are other folks that have an accountability relationship. This is really saying there's an accountable relationship for the execution. Okay, I look at this one as accountability. Number 2 is physician-directed medical practice team. We traditionally, we say, you know, the doc is responsible for everything because he's the charging unit, but the team around them has to be something more than just putting people in a room. We have an opportunity to have, the physicians need to be working at the top of their skill level, just as the nurses need to be at the top of their skill level, and everybody else needs to be at the top rather than what we are with a volume-based system. I'd be happy to see it. I get paid more if I see a bunch of easy cases than this one Mrs. Smith who takes a whole hour and brings in all of her stuff, and I never, you know, it's one office visit. So we need to get, again, the team to execute this care. Whole person orientation instead of just Mrs. Smith, the diabetic. It's Mrs. Smith, the diabetic business witness whose husband died a year ago and now has a substance abusing son in the basement. Just basically, there's a lot of other stuff going on. We need to look at all those pieces as to why someone is not compliant. Coordinated, integrated care across the system. Integrated care, coordinated care is now an expectation. Remember what I said about fishing and football earlier? We're all in our own unique boats, fishing and catching as many fish as we can. We can't have that. We've got to figure out how we play football. How do we actually run the plays? How do we get over ourselves and call the folks who have the information so we can work together? Well, much of what I talked about so far has been about quality and safety. It says they're a hallmark. Quality and safety are going to be about, you've got to have data. But the data isn't about just proving that you're good. It's about using the data to continue to improve what you're doing. Quality, okay, quality and safety. Quality is about documenting what you have. And now PQRS, everything else, we're going to get paid that way. But safety, we've got to eliminate unintended consequences of care. That's a big problem. That's waste in the system. Enhanced access, we've got to figure out how people have access. We had discussions earlier today about apps, and but there's other our office hours. How do patients have enough information? How do we see them so they don't end up with, you guys know that already. That piece is payment that recognizes value. Now, the point I want to make on this one is this was very, very popular in 2007. Okay, and the provider community looked at this and says, and we can do all that stuff if they pay me. So let's get to work and do all this stuff. Matter of fact, we'll get to work. And what did the insurance companies say? The insurance industry said, well, before we pay you, before we do number 7, you'll have to do the first 6. And we're going to have to justify, and actually, you have to prove that you can do those first 6. So they came up with this wonderful thing called HEDIS, and they have ways of measuring. You need to become certified before we can pay you differently. So you'll need to do these things, and you'll need to get all this stuff. And then we came up with there's level 1, there's level 2, and there's level 3, and all this stuff to be certified so that someday they'll pay us. So what happened was, do you think people got a little discouraged? Do you think that there kind of was a drain on the momentum moving forward with medical home? It's like, matter of fact, the other thing is the providers very intelligently had to begin to say, well, okay, why would I do this stuff if you're not going to pay me? And if I don't know, why would I invest in all this stuff? That's a great idea. Thanks. I need to go see patients. So that's kind of where things have gone. There's been a waning energy. What just happened? What just happened was a game changer. What just happened was macro. The federal government just said, we think this thing's got legs, and this is actually the key to us changing the healthcare system. So we are going to change the reimbursement around value, and we're going to pay you for this stuff. PQRS, all this other stuff, these are all examples of things. Those are metrics that you can now supply information, and your payment will be tied to it. All of a sudden, this just changed, and medical home, like I said, it's 40% of where we need to go, but it's the first 40% you need to be doing. Next slide. So this is just a little bit of medical home commercial stuff, but medical homes can help you with transitions, reduction of preventable readmissions. It helps you with patient engagement, and basically, more importantly, self-management. How do we help our patients take better care of themselves? This is now a place where we're going to actually begin to coordinate some of the resources. And coordination of resources is going to be important going forward. Next slide. I want to give you 3 slides. There's some people kind of, what's medical home, what's medical neighborhood, what's an ACO, how do I separate all this stuff? It's so confusing. I want to just kind of tell you, let me give you the 3 things. Medical home, it's not a single place or a location. It's a concept of accountability, okay? We're responsible for this population of patients. We're going to do all those 7 things, and we're going to basically assume responsibility for it. It's going to be based around the patient's needs. It's going to be accessible, comprehensive, coordinated, and focused on quality and safety. We're going to focus on blocking and tackling. Someone is going to say, okay, we're going to assume responsibility to be the quarterback on this particular play. Okay? Next slide. Medical neighborhood is an extended version of that because every one of our medical homes have to practice within a community. So Elliot Fisher coined this one, medical neighborhood, and it's to refer to my medical home, but I've got a hospital and long-term care and pharmacists, and how are we going to coordinate within all of these different folks? So the concept of this local phenomena, okay, your local medical neighborhood, is a very important concept. Your hospitals right now, I just would remind you about your medical neighborhood. Your hospitals right now have a gun to their head with regard to revenue reduction. They're changing the way they do things. Everybody's got some different thing going on. How do we coordinate those resources? Okay, now, next slide. As the community comes, well, go back 1 slide. One thing that's important about a medical neighborhood is a medical neighborhood will not, there are a lot of people that are talking about bringing together community and organizing these medical neighborhoods. What the research has shown is medical neighborhoods don't work without medical homes in them. Okay, you've got to have that full source of contact with the patient to actually be able to execute this effectively. So some folks, this may be a health system. A lot of health systems have tried to hire a bunch of primary care, but if the primary care doesn't know how to do the blocking and tackling with the patients more effectively, these don't work so hot. I was medical officer for the largest health system in Iowa, and we were a hospital system. And we had 420 physicians under me working with this whole thing. And I was living the pain of trying to do this before the concept of the medical home. I was gone by then. But the whole point was, I understand this. Just putting the same label on everybody doesn't make you effective. What doesn't make this effective, though, is having that primary care engaged and operating.
And vice versa. Because I have two sites that just finished the patient-centered connected care recognition with NCQA in a community where the primary care provider doesn't want anything to do with the patient-centered medical home model. So we're in this, here we are, unable to latch on or connect to something. And so when we sign co-management agreements, collaborate our care for our same patient, they hang up the phone.
Yep.
Literally.
So the whole point is you've got to have that engaged.
You have to. It's
Yep.
It can't be in the neighborhood if there is no home.
Now, if we bring the medical neighborhood together, what we're being asked today to do is, in a value-based system, is to bring these medical neighborhoods together and to assume risk. That would be an advanced payment methodology, right? Now, there's two ways we can do that. We can do it as an ACO, or we can do it as a managed care organization. ACOs and MCOs are doing the same thing. An ACO is a provider-led, the next slide. An ACO is a provider-led organization whose job it is to assume responsibility for a population of patients. Provider-led is the key word. The providers are coming together and saying, okay, we'll take care of these people for this number of dollars. Managed care, an MCO, is a payer-led initiative. An insurance company says, we'll assume risk for this thing, and then we will try to steer it through policy. We'll steer the provider community. ACO and MCO, two sides doing the same thing, one convened by the provider community, the other one by the managed care community. I'm very sensitive to this right now because in Iowa, our Medicaid just decided to go managed care. Okay? The difference is, if you have to actually transform the system, who could do a better job of transforming the system? The provider community is incented to actually do care differently, or the insurance company whose job is basically to pay less money. Their biggest lever is rationing. Okay? Can we actually work together in different ways to steer this thing differently? So I'm not trying to build a case for one versus the other because they both produce costs, but I'm very pro provider. Get over yourselves. Let's figure out how we actually do this stuff. So in ACO, what's out there today is medical neighborhoods. All of us are being encouraged to assume risk at some point. That's going to be your advanced payment methodology. Next slide. So, and again, this is kind of saying what we said, but this is from Aetna. At the center of the integrated health delivery is high-performing primary care providers who can serve as a medical home for the patient. Basically underscoring what you just said. Even if we build this system, it doesn't work if you don't have that integrated touch point with the patients. Next slide. Well, these are just some very quickies. They're in 2007 now, there have been several demonstration projects around medical home. For those of you, you're kind of going, does this really work? Actually, it does. Colorado showed that there was a 15% decrease in ER visits, 18% decrease in hospital admissions. Next slide. Another project in Nebraska, significant reduction in ERs. I mean, there's all kinds of data out there. Enough data that the feds have said, this looks like what we need to do. Next slide. So other lessons that are really important. You can't just do it. You can't just flip the switch to medical home. Matter of fact, what's found, it takes 18 to 24 months for you to develop the effectiveness of being a medical home. So just know that it's going to take 18 to 24 months. It's going to be a glide slope to get better. What happens, though, is it appears that the effectiveness increases over time, and it continues to increase. We don't know the end point. The other interesting comment is that I've heard folks writing this and say, so when are you done? How do you know you're a medical home? And the answer that most people say is never. It's a process. It's a continuously evolving thing as we get better and better and as we react to the needs within our community. That's kind of what we're trying to do here, is have our clinics embed those 7 principles and begin to kind of drive that stuff forward. Next slide. So, and you are all asking yourself this right now, like, why am I here? Okay, it's getting late, I'm hypoglycemic, it's like, why am I here? Okay, now we're gonna go to TCPI, okay? So I've given you all the glittering generality stuff. This is, I'm just gonna kind of walk through some pretty granular stuff on TCPI. Next slide. So you all know that we need to move through the phases. We need to imagine that at the practice, we're gonna process, map out process. Now we're gonna start running through the process on site, doing performance PDSA cycles to improve what we're doing. We're going to use data to improve the process, and actually, at some point, you're going to be able to demonstrate value. You're going to be able to measure reduction in cost, improvement in your overall performance. Okay? We haven't done that in the past. Remember what I said? Like my 107 diabetics knew all of them, but I couldn't tell you what my overall effectiveness was. Wasn't caring for them. You're going to have that. Next slide. So this is kind of a gross oversimplification. I'm gonna say basically this came from Susan Brown so this is your bucket list slide. Susan and I were having a discussion about what is CMS really asking us to do with this. And number one is move toward the patient-centered medical home model. Number two, we need to measure quality on a monthly basis. This is not, and measuring quality on a monthly basis doesn't mean like thou shalt report this and send it to CMS. What it means is thou shalt get the data and look at it. This is not about comparing yourself to someone else or putting in your newspaper. It's about getting the data and saying, where are we? Where are we? I drove here from Fargo last night, and I kept asking myself, where are we? Okay? But the fact is, you got to do that. You got to start asking the question, where are we? Okay? Assemble a learning community. That's what we're doing right now. This is kind of an iteration, but we're going to be a bigger and bigger learning community. We've enrolled you, but now we've got to engage you, and then we've got to transform you, and that's why we're here. Okay. And interestingly, we need to assess our progress. We'll continue to take the data flow and look at where we are as a group, and then we want to try to capture lessons, and we're going to share them with the rest of the country. And you're all going, I'm not sure I got anything I can take to the rest of the country. And I got to tell you right now, the rest of the country doesn't know how to do rural frontier healthcare. I'm going to tell you another thing. The most important reason for you to be here. We've got to make sure that we protect ourselves in a changing reimbursement system. We need to have a voice that's going to go back and say, excuse me, that won't work in South Dakota. You're going to put us out of business. All this value-based stuff is fine, but we have a lower volume, and we've got to figure out how are we going to build a sustainable strategy to meet all the needs of all of the citizens in this country, not just those in Pittsburgh or the demographically concentrated areas, Chicago. Okay, it's easy to decrease, in my opinion. I'm going to be with Marty gone here, but it's easy to decrease the unit cost in Chicago and then make it up on volume. Here, we decrease the unit cost. Where's your volume? Buffalo? I memean, we don't have a ton of extra people here. We're trying to do the best with what we got. So one of the reasons we need to be here and together is we need to capture our lessons. And I want to know what's not working. But then so that we can package it and take it back up and say, you got to be thinking about this when you build the reimbursement system. Remember that we're all in this kind of a big innovative thing. The feds you've never been in this situation before. They're going, remember you're in this 140,000 innovator group, and they're going to be building the answers for everybody else at some point. This is kind of an important place to be. I hope you feel kind of important right now. Like, crap, we're going to make sure they don't screw this up, okay? So, there are two pieces I want to talk about. All of this has been glittering generality stuff, but now there's two things that the feds are going to bring to us. Everything we've been focusing on so far has been on enrollment, okay? There's going to be an assessment tool that we're going to use to assess all of the practices. Some of you have been assessed and some of you have not. But the goal is to fill out a practice assessment tool within the first 2 months of enrollment. The practice assessment tool will give you, that's your starting point, okay? There is also a complementary change package, which Marty kind of alluded to, but the change package works hand in hand with the practice assessment tool. So we'll look at this, we'll find out where you have gaps and opportunities. We'll pull content from the change package in, and we'll be working with you to kind of tune the fiddle on that stuff. And then we're going to look at our data and we're going to see how it's doing. And after about 6 months or so, we'll do another practice assessment tool. And we'll see, are we getting better? What are our new opportunities? Because by the way, the system's a different system than it was when we started this thing. Okay? And it's going to be a complementary relationship between the assessments and the content packages and the on-site instructions we go forward. Kind of make sense? Okay? So what's in the change package? Okay, the change package is this national content for TCPI. It's written by a national content developer, so I ain't doing it, but it's some of the best minds in the country pulling this stuff together. It aligns with the practice assessment tool, and it's organized in kind of 3 levels. Marty actually described it pretty well on his slide. Next slide. It's in goals, objectives, and tactics. Marty defined it as primary drivers, secondary drivers, and then tactics. There are 3 primary goals for this thing. Okay, so and this is again what was kind of on Marty's slide, and I've alluded to this already. The 3 big goals of this campaign are, you see PFE again, enhanced person and family-centered care designs. And they have a whole list of objectives under that. There is provide continuous data, data-driven quality improvement. That's the one where it feels like, yeah, that's all this data stuff. But it's not about comparative reporting. It's about using your data to change the way you do your care. And then finally, creating sustainable business operations. I thought it would be good to go through each one of these and list some of the objectives so you see what's on those. But first, this was Hawaii about 6 years ago, I think. And my wife and I were on a trip. And remember that first objective there is patient and family engagement. I like to use this slide to describe patient and family engagement. And the reason is because this is usually how we talk to our patients, or better yet, how we listen to them. And the concept, I thought it was kind of funny the first time I did this. I put it up and I said, well, we talked to this guy, but we're not really listening. And we're listening to him, but he's not really saying anything. And that's usually how we have dealt with our patients most of the time. And so it's kind of a sad commentary, but I was really proud of myself. But about 4 years ago, we had a patient safety conference, and I was really going to do a lot of PFE stuff. That's my passion. So I brought in, and Marty was talking about PFAS, okay, patient and family engagement councils. So I invited 2 hospitals to talk about their patient and family engagement councils at our patient safety conference. I thought this would be really cool, and I thought I'd really be innovative, and I'd invite a patient. So I had a patient from Omaha come over, and I had 2 hospital leads talking about how they did their patient and family engagement councils. And I did a little patient family engagement discussion in the beginning. Hospital 1 got up and gave their wonderful discussion of stuff, and then Hospital 2 got up and talked about their wonderful discussion, and then the patient got up. And the patient said, this is really good. I'm so happy to be here. And, we as patients, we actually, and he was really a humble guy, a nice guy, and he said, but I think it's important for providers to understand that we look at things differently than you. We see things differently than you do. Like, for example, I just love this picture of Dr. Evans up there, but has anybody noticed that Dr. Evans has 3 legs? And I'm going, what? And it was the highlight of the whole stupid conference. And we're kind of thinking, no, that was really stupid. But, and the fact is, the take-home message there is that, I know Marty went on, we had a very long presentation earlier, but I wanted to build the case that patient and family engagement is a huge piece of what we're doing going forward. If we just do number 2 and number 3, which is going to be natural for us, if we only focus on the quality stuff and the cost stuff, we're going to miss the boat. I think I've described it already, but with this pie chart of our opportunity, 20% of it is driven by healthcare, clinical care, tuning that fiddle. Another 10% is driven by environment, and the other 70%, and there are 4 different models I've seen on this. The other 65 to 70% is driven by either patient choice or social determinants of health, education, all those kinds of things. And we have got to figure out how, frankly, we aren't the money. That's where the money is. We're just going to be held accountable to try to figure out how we manage that better. So it's the opportunity for us is for us to clean up our house as quickly as possible so that we can leave the rest of the deal. Okay, so the components of person and family-centered care, these are the components that are written in the change package. And you look at these and you go, I mean, I just kind of summarized them, but you look at them and you go, okay, we have to develop skills in patient and family engagement, team-based relationships. That doesn't just mean you and your nurse or you and your office staff. It doesn't just mean your little local clinic. It doesn't just mean your clinic. So within how are you teaming up within your community? The term I like to use is population-based community applied. You're going to have to figure out how you do that. Population management. Dan? I'm sorry, Susan.
Oh, sorry. I was just going to say that in terms of context for the change package, last summer, CMS asked the PTN and the regional extension centers and the QIOs to identify within our own communities high-performing practices. They had to be practices that were taking on risk and thriving in that environment. There were very few practices, high-performing practices. CMS wanted to do case studies on, actually flew people out just last summer. Do these practice sites, do an on-site depth assessment that's making them thrive. From that case study emerged those three topics that Marty and Tom keep talking about. And the reason I bring that up is this is all not just some policy person at CMS sitting there saying, oh, this is what we think the top three focus areas should be for environment. These comments are coming from people who are actually doing it and succeeding it, and they're doing the name these folks are not just something that a policymaker made up.
That is such a good point. The content in the content package has been driven by those who are doing this successfully in the industry. Matter of fact, the content that is being designed around the person and family engagement, there are practices that are champion practices around the country that actually have this stuff in place. So that's a really good point. Thank you for making that. Team-based relationships, population management, the practice as a community partner, I kind of alluded to that already. Coordinated care delivery, organized evidence-based care, and then enhanced access. The second group, remember, continuous quality or data-driven quality improvement. Look at number 1, engaged leadership. I'm going to put your memory back a little bit because in Marty's blizzard of slides, he had that one that looked like stair steps, and that was Bodenheimer's slide on the components you have to have, and there were 10 blocks, and number 1 through number 10, and they changed in colors. And the number 1, which is all by itself at the very end, was red and it was hard to read. But anybody able to read what it said? Leadership engagement. Number 1 is leadership engagement. So now the question I would have for you is, what does that mean to you? Who is your leadership? Sometimes, depending on what you are, it could be you've got a clinic system. Maybe you're owned by a system. Maybe you have 3 doctors in your group, but there's Dr. Jones who is like the one, sort of like, you know, when he speaks, everybody listens. But you need to figure out who is your leader. Now, the primary role of the leader is not to say, follow me, boys. Usually effective leadership in this situation is getting everybody involved and barrier removal, trying to help people get the stuff out of the way that keeps them from moving forward. But engaged leadership, that will be one of the topics we're talking about a lot as we go forward. Engaged leadership, quality improvement strategy. You got to have one. How are we doing it here? What are we working on here? We got PQRS measures. Do we just measure a bunch of crap and send it in to somebody? Or do we actually have a strategy behind how we're doing this? We've got 4 PQRS measures, but they're actually measures of a process that we define. We're continuing trying to improve that. We want to see how our PQRS measures move. Transparent measurement and monitoring. Here's an interesting thought. Do we gather our measures and then just send them off to somebody else? Here's a thought. How about gathering your measures and posting in the nursing station? Whoa. What if my team began to own our performance? Okay? Optimal use of health information technology. I don't have to beat that one. We've been working on that one for 10 years, but the fact is, a lot of the time we have health information technology strategies that don't measure what we have to have. We're going to have to work on it. Yep.
Posting the QI is also a requirement in all of the recognition programs for patient-centered mental health, not only with your staff and then having patients follow it, but also disseminating that information to the public.
Commitment to transparency.
And
yep.
Required in all programs.
Yep. Good point. Next slide. So sustainable business operations. These are just the objectives that are listed. These are the sections underneath that. Strategic use of practice revenue, workplace vitality, and joy in the work. A lot of that is basically, what's the culture here? Are we fun? Is this a good place to work? Am I encouraging? Because I got to tell you something. If you have an onerous, pain in the ass workplace, I don't know if I can say that. But the fact of the matter is, some of your best solutions are going to come from the people that are at the bottom of your rungs. Okay? They're the ones who are actually administrating the process, but they think you're stupid because you won't listen to them to actually fix their problems. Okay? You got to have an open, and you won't do that if it's not a fun place to work. If they don't feel safe, they aren't going to tell you if they think this is dumb. They're going to take their paycheck and they're just going to go home, or they're going to go get another job someplace else. And then efficiency in operations. So phases of transformation. We've seen those. I hope you'll look at that a little differently. Now, how are we going to, back one slide, how do we move down this road? The practice assessment tool is what we're going to use to see where you are. The feds have specific pieces in the practice assessment tool, the way they measure this stuff. Like when you take your practice assessment tool, they'll be able to give you a grade to see where you are in aim setting, data use, aims achievement, all of that stuff. There are pieces in the practice assessment tool that talk about the sustainable business operations. They talk about your use of data and your patient family engagement. Okay? So it kind of all comes together in that piece. Next slide. So the practice assessment tool, where we are, this is now the second version of it. Basically, the first version came out to the PTNs in about November, December, and it was basically too complicated. We sent them back to the drawing board, and they come up with a shorter version. But so the reason I'm telling you this is they're not going to get another one. Okay, this is where we are right now, and we're basically, what we're being told is get doing it. Okay, the next thing, as a matter of fact, much of the PTN project, the TCPI project, has been about getting people enrolled. We're at the enrolled point. Now it's about execution. So now we're starting PATs, get to work. Again, the practice assessment tool will align with the change package so that if you identify gaps, we'll be able to tie things to information through the change package. It defines an improvement pathway. If this first measure is just a launch point for you, we're going to do this about every 6 months. Okay? Questions? Okay, next slide. So we're a learning community, breakthrough series model. How are we going to go forward? I want to close with kind of one concept on the concept of requests and offers. Okay? We don't know how to do this. We don't. We're learning from each other. There are different folks in here. I bet everybody in here has something. You have some things you don't understand, you're scared to death, and you have some things that you actually can offer to everybody else. There are things you know that others don't, and other things that they know that you don't know. Next slide. So I want to kind of touch base on this whole requests and offers thing and just talk about how do we grow our knowledge? How do we do this thing, put a man on the moon? How do we go there? And this is just a very quick slide deck that was, it's a little bit of a mind stretch, but not too bad. It's very intuitive. You'll get it very quick. But the whole concept of requests and offers. And that's the way we're going to operate. The expectation, you guys aren't even in the TCPI and you're here. Thank you. And we're going to ask you for stuff. And I want to thank you for offering to come today because you brought some unique things that we're going to talk about later. So I want to thank you publicly before we even go there. Okay? Okay. They offered to, I'm going to talk about that, okay? But let's go, next slide. So if you look at resources, like what I got, and what you got. There's stuff that I got that you don't got, and there's stuff that you got that I don't got, right? And the stuff that, next slide. So the stuff that, and you can kind of put names to this. If I got it and you got it, it's public. If you got it, I don't got it, it's yours. And if I got it and you don't got it, it's private, okay? And if neither one of us have it, it doesn't exist. We don't have it. But wouldn't it be nice if we did? And by the way, we need it. We got to figure out how we go there. Next slide. So this is public, and I understand. And back, next slide. And we're back to this is mine. It's mine, and you can't have it. And this is yours, and I can't have it. But this is really the opportunity point. How do we tap into the stuff we don't have? And the way we do it is we do it with requests and offers. Next slide. So a request is you ask me for stuff, and I give it to you. Okay. So basically, and an offer is that I offer to give you stuff, and I give it to you. And what ends up happening here, obviously, is we expand the knowledge of both. And that's really good. Now, that's all nice. Thanks a lot. Kumbaya. Here we are in South Dakota, you know. But the fact is, this is kind of the spirit of what's going on nationally right now. We have the PTNs. The PTNs are doing this. The feds are doing this. We're doing it with the private payers. Everybody's got to figure out how do we do requests and offers. And that's why what is so special with the Avera folks right now is that they are not in our PCPI family here, but they offered to come and talk about some of their stuff in our last session. So it's a perfect example of we just got to get over ourselves and get together and do stuff together. So I'm going to stop there. And just ask, just see if anybody, go back one slide. Just stop there for a second, see if anybody has any questions. Okay, everybody understand? And I haven't beat you up too much, right? You still go to the data presentation. I'm going to try to accelerate things a little bit because it's a beautiful day and we're all getting brain dead sitting here. So, questions about, anybody have any questions about kind of what we're going to try to do? Then I want to quickly go to data. And just, this is a big topic of what we're talking, a big piece of what we're going to be doing. But, and this is not going to be a real long presentation, but this is usually the biggest hang-up. Whenever we bring together folks, whenever we bring together the practice, everybody wants to camp on, well, we don't have the resources. We can't do this. We can't report this. The data's crap. And I've heard every one of those things. And I want to have you take a step back and start looking at the data differently. And that's what we're going to try to talk about here. Data is no longer, I've kind of alluded to this already about the difference between comparative reporting, public reporting, okay? Performance improvement, comparative reporting and performance improvement. So, okay, so these are the objectives. Explore the complexity and challenges of different data types and sources. Explain the difference between using data for comparative reporting and performance improvement. This is huge. And if you don't take anything else from this, from our discussions today, it's that you got to have the data, but you got to use the data locally to affect change. It's not just anymore about getting your data and sending it to somebody else so they can compare you against somebody else. It's about you using your data to drive your own change. We're going to talk about the flow of data in Compass PTN. That's one of the reasons Susan is here today. And we're going to consider clinical strategies that effectively use data to shape clinical care and culture. One of those is we're going to have a breakout session after our break. We're going to have some folks talk about how they're using data to affect change. So again, you've seen this about 1 million times, but this is what we're trying to do. Next slide. And you already have seen this a couple of times. Next slide. So, how many of you have had to talk to your docs about data? It's a wonderful experience. Would people agree with that? It's one of the most heartwarming, and they are one of the most receptive groups to information that there are on the face of the earth. Would you agree with that? By the way, this is the most smiles I've seen in the room today because everyone's going, and shoot me now, right? Okay. So what do they say? What do they say? That's crap, usually, right? Is it pretty much, they can't say that, who came up with this stuff? Give me, come on. What else have you heard? What's the N? Oh, that's actually that's a sophisticated user. What's the N? But it's basically, it's crap. You just say, what's the N? Okay, what else? Our patients are sicker. Oh, I've heard that one before. And you know what? They might be. But my answer back would be, and prove it. You got age sex adjustment that you can prove that they actually are sicker. But, you know, again, but they might be. Others? What else have you heard? That's exactly right. That's exactly right. Well, we do a good job. It's just that the data doesn't show it. The definitions are bad. Who came up with this crap anyway? Steve? Is it oh, that's a good one. Yes. Has it been validated? Yeah. Yeah, that's like, is there really evidence behind it? You know, it's interesting. I'm sorry, I'm being facetious with the provider community, but since I'm the only doc in the room, I mean, you guys can throw stuff at me too, but you know, frankly, we're really great at pushing back. I love that one, is the data validated. That's actually like they're acting. Often they will push back with a sophisticated argument that basically says it's not any good. Is the data validated? I love that one. Other comments? Well, one of the reasons they do this is they're probably right. This is a very complex issue. And what happens is we're always looking at one smidget, and because we're always looking at one situation, there are like several ways that they can poke holes in it and say, is it any good? So I just want to kind of talk about data for a second. Data means that the data isn't just data. The biggest thing about data is it depends. When you talk about data, they may be right, and then you have to kind of go through and dissect it back, but it's basically the use of the data depends, and you have to be thinking about all the different variables. So the data comes from, usually from different sources. There's claims data and clinical data. I remember back in the 90s when we were doing this stuff, and there were two places where we could get the data. Okay, one of them was from claims that we had submitted, and the other one was in our chart. In our chart. Well, this is where truth is. Only here. Okay? By the way, we can't get anything out of this. Okay? But it's in here, the holy chart. And so what we had was, that was the 90s, and there was clinical data. So anytime anybody brought any performance stuff to us, we would go, that's crap, it's clinical data. You can't say that about our patients. You can't count my overall effectiveness for diabetic care by counting how often I can say, because those are just charges. How do we know there's not some error in the way those charges were put together? That's crap. Okay, so clinical data versus claims data. Okay, doctor, fine. So now I agree with you. We need to have clinical data. What do you have for clinical data? I don't have any clinical data. It's in my chart. Well, how do we get the clinical data? I'll need to hire somebody to go and do all this stuff, or I need an electronic health record. Now we're talking the next 15 years. Okay, we'll put in an electronic health record, and they'll theoretically automatically pre-populate our register. You know where we are now with the electronic health records? The electronic health records populate stuff into a PDF format or something that you now have to go back and manually and pull stuff out of the PDF. So it's like, but still, holy chart. but I can't use this crap. You know, so the bottom line is, here's the encouraging thing for all of you who are beating your head against this. Okay, the problem has been that we haven't had standard definitions. If we have standard definitions, we now can have the stupid IT vendors build consistency into how they do stuff. It's sort of like we had the vehicles, we just didn't have the common thing we had to pull out of the vehicles. So, and has this been to the IT vendors' benefit? Oh, we do all this great stuff. Doesn't our chart look good? Okay. Did it pull the information I needed to have? Not necessarily. So the beauty, I'm just telling you what gives me hope, the fact that we're getting standardized metrics. It's now a design principle, Mr. IT vendor, that this stuff auto-populates into registries, so now I can take stuff out. Okay, yes?
We used today's CMS webinar on this, because it changed meaningful use for the HR incentive is now advancing care information, because as they went around and listened, the meaningful use program gave data that wasn't meaningful.
There's two things you said there. Two things you said there that are really important. One of them is that the meaningful use wasn't meaningful, which is an important conclusion. But the other thing, I just want to kind of point this out. They listened.
Yeah.
They were going around and they were looking around what's going on. That's a difference, folks. We haven't seen this before. See, the feds are serious about how do we change our direction. In the past, it's been, hey, this is the way we pay you. Have a nice day. Okay, so they listened, and I just want to camp on that. But you're right, and what we're finding is the course is this right now, as we're doing that. They found something, they have to make another course adjustment. So that's clinical and claims. And I will tell you, on this clinical versus claims, clinical's not perfect, claims isn't perfect, but you need both. You need claims data. Why? Because it's easy. It may not be perfect, but it gives me directional, okay? And if it gives me directional, I can use that to start to change my organization to kind of move in the right place, okay? So claims, if nothing else, is going to give you a basic direction, and now you can hone down using clinical data. Clinical versus claims, okay? Now, scope of the measures. Process measures versus outcomes measures. Outcomes measures, and they die. Okay, it's like this is the result. Okay, the problem is someone mentioned earlier what's the N, and the N often is this and they died. Well, if you only have 4 of those, that's not a big enough sample to draw any conclusions. Okay, so often, like on patient safety, the outcomes measures. We may not have a large enough N to get good outcomes measures, so we have to use proxies called process measures. What are the things that we know that if those happen frequently enough, it will alter this? This is part of our science today, folks. We're going to have to figure out how we use both process measures and outcomes measures going forward. Some of the measures that you're going to be seeing through PQRS are outcomes measures, but there's some that are in there that are process measures. You're going to see, especially on some of those utilization measures as we go forward. Just know that you're going to have both process measures and outcomes measures. And this is another place where physicians will argue. It's not an outcome measure, it's silliness. You're making me count how many of these little ditzels I do, and that's the important thing. Wrong. If you're doing those, it influences those. So we have to just recognize that they're both process measures and outcomes. You with me so far? Okay, the last one here, comparative reporting versus performance improvement reporting. You do understand that every bit of our DNA to this point is really about comparative reporting. Okay? We have been gathering data since 2002 when the core measures were released, and the reason was they needed our data so they could prove we were good doctors. And if they proved we were good doctors, we might get another pork chop. Remember HEDIS on medical home? If you can check these boxes, then you will qualify for this next pork chop. Okay, a lot of this stuff is comparative reporting. Comparative reporting, here's a scatter plot. Comparative reporting says I'm this dot in this scatter plot. Okay, performance improvement reporting is about moving my dot in the scatter plot. We're going to, and so comparative reporting is a snapshot in time. How did I look on that particular date? How did the scatter plot look on that particular date? Performance improvement reporting is, this is our process, this is our date here, next month, next month, next month. It's run charts. It's how do we, and our job is to have this go, improving. Comparative reporting is a snapshot in time that you take maybe every 6 months to every year to know how you look compared to everybody else in the room. Okay? Process improvement is how you look compared to yourself over time. Are my processes effective or not effective? And your numbers for PQRS, the only way you're going to improve your numbers are going to be looking at your processes as you go in time. You guys with me on comparative reporting versus performance improvement? Okay, so I basically take these things, I throw them together into a Rubik's Cube. Next slide. And then this is just a nice way of saying how to use the data. It depends on what question you're asking. Which square are you looking for? Okay, so none of these are right and none of these are wrong. They're just the factors that you've got to have in the back of your brain as we do this. You've got to be sophisticated. Whenever you talk back to your docs and they say this is crap, you say, well, it depends. By the way, the answer, it depends, is the right answer for just about everything you ever want to say. Okay, is it this or this? Well, it depends. I think that's wrong. Well, it depends. So just kind of be ready to kind of figure out how you do this, because you got to kind of back them up and say, because everything they're doing, they're coming in with real concrete thoughts. Well, it depends. Now let's take a step back and let's kind of take this apart. Okay. All right, next slide. So back to Susan's slide. What is CMS asking us to do? Again, we're moving toward PCMH, measure quality in a monthly basis. Guys, every 6 months, even every quarter, is not frequently enough. You'll make that you did the change. You got to look at it on a monthly basis. Because when you're looking at it on a monthly basis, it's not a question of looking at it like, hey, there's a report. It's not that. You got to talk about it with your staff. Here's what our numbers look like. What I would recommend that you do is get your numbers, have a meeting where you discuss it over a drug or something, post them in the nursing station, and have it be the thing that defines your culture. Use your data, okay? Okay, next slide. So I want to just use this to underscore one of the things we're trying to do within Compass is to meet you where you are. You're all at a different place. So you've got different data. I don't know what your data is. You're the ones who know what your data is. I just care if you find some and you use it now. What I care about is you changing your culture. You embedding in your culture that discipline to look at this stuff and actually change our processes. Okay? So meeting you where you are, next slide. And we have several resources that are available. I'm going to kind of talk about how the data flows. You're going to generate your data, and then you're going to send it to us through a web portal, but you don't really send it to us. We have a vendor who is going to be doing all of our data collection and our aggregation, and that is Intelligent. Intelligent is a QIO, QIN in Des Moines for Iowa, Illinois, and Colorado. Susan is here representing them. But Intelligent is the data receiver and aggregator for the whole Compass PTN. They'll be taking your data, and then we're going to kind of put it in a big pile, and then we'll slice and dice it and try to figure out how we actually use it for comparative purposes to give you some information so that it helps you do things differently. So, now by the way, we can receive the data in 3 ways. Okay, we can receive it directly from your electronic health record, or if you have it kind of pre-populated into registries, like in numerator-denominator numbers, we can kind of take it that way. Or if you want patient-specific data that you want to send, like chart by chart, we can take it that way. So we can kind of take that any way that you want to have it. And it's a web portal. The reporting will come again. The name of the tool is Qualitrack from Intelligent. This does a couple of things. This is going to be gathering the information that you report to us. So we'll have your information in place. The other thing that's a unique thing that we learned basically from the HEN program a couple years ago is when we're doing these cyclical changes, we have our process, we do this stuff, we look at our data over a period of time, we decide we're going to change our process, we make some changes, we look at our data for a period of time, we change our processes, we put a different process in place. What happened is we were finding we weren't capturing the changes that were made. So what this will also do is capture your work plan and the changes you make over time so that we can, again, try to track what are those changes that make care better. And again, imagine now we're kind of trying to build a great big database of learning as we go forward. So that's the PDSA work plan tracking. And there's an optional care coordination tool. We'll have technical support available for you on this as well. Next slide. This is kind of the other slide was all words. This one's kind of a pictorial version of how this looks. This is you. You're going to be doing PDSA cycles. You're going to have your data, and you're going to have 2 jobs. Report your data and use your data. So on reporting your data, you're going to be sending the stuff that you choose to send to us to Qualitrack, which is Intelligent, our data vendor. As I mentioned, we can take it in 3 different flavors. Okay, so we'll take that data, and then Qualitrack processes it, and we'll send it to Compass. And then Compass, we got to do several things with your data. We have to send certain parts of it to CMS. So there's reporting will have to go to CMS. We're going to use it to kind of build build content for learning communities. Oh my gosh, what did we learn from the data? Okay, so we'll kind of use that as we can kind of drive change. Technical assistants, the QIs who are going to be able to come on site and help you do things differently, will help them with their coaching with you. And then also the information then is going to be coming back to you. And your job is to use the data to try to figure out how do we do this better, different, moving forward. This is a list of some of the measures. Susan, did you want to say anything on this? Or
I would just make the point that the data that's going upward from the PTN to CMS is not provider level. They don't want individual provider data. In fact, they don't even give us a mechanism to report that. We don't have any way to report individual provider data. So if there are concerns on the parts of providers about the use of the data that's going up to CMS is all aggregated. The data that's coming back to you is only your data. So you will be the only ones to see your own data.
yeah, so but we will be aggregating into piles of data that we can use that you can compare your data against. So now we have to figure out what that means. Do we have South Dakota? Do we have Compass? Do we have, we're still trying to figure out exactly what the comparative mechanisms will be, still developing that as we go forward. This is a list of measures, just to kind of show you some of these. These shouldn't be real strange to you, but there's several. Obviously, you can see we have some process measures, some outcomes measures, some care coordination measures, patient safety measures. It's not all about one or the other. There's a lot of PQRS in there, so these are specific PQRS measures that you can choose: hypertension, blood control, appropriate uses for asthma medications. Beta blocker use, low back pain, imaging studies, those are all PQRS measures. We also have chosen, everybody familiar with Choosing Wisely? Okay, Choosing Wisely is a stewardship program nationally. I don't know if I described that here yet. I know I did in North Dakota, but everything's blurring together at this point. But Choosing Wisely basically is a stewardship program, much like the low back pain analogy I used earlier. It's trying to keep you from doing things you shouldn't be doing. And we've used several things that are proposed Choosing Wisely measures, but those are things, we believe that the Choosing Wisely measures are things that CMS is going to camp on because they're evidence-based and they're promoted across the industry. So these are these are not the gold standard, the end deal, for examples of different things that we have going right now. Anything else to say on that?
We ask participants to report on as many as possible, but you're not required to report on all of these measures. If you're already reporting PQRS, that would be an easy win for you to report those, but you need to be looking at those.
Yeah, so what we recommend is you're reporting this kind of stuff. For performance improvement, I'd start with what you're already reporting. And then let's process map out what you're doing, and let's work on trying to change the process so we can make it better. Okay?
So when we're reporting on these measures, for all provider type right now, most of them are reporting to claims, and the EHR system, they're not reporting to registries. So to get this data in these other measures,
what's my data source?
How will they get that? How will they get that? Because they're right now.
How do we populate the data?
Yeah. When you mean for the other measures, you're saying non-PQRS? No. I mean, we've got some PQM that crisscross with that. With those. Is that going to be the possibility to report that through that mechanism?
Yeah, we'll start with where you're at today. What can you pull? What are you pulling? And then we'll start by process improvement on those things. And then the next logical question is, now how do we get that into data?
Yeah, because those PQMs are not really good outcome measures for our provider type.
Right.
Which is a
But I want to take us back. This is a very important discussion. Okay, I want to take us back just 1 second here. We have to remember that why are we getting the data? It's basically for us to use it to do performance improvement. So start with what you got, we'll get it together, we'll kind of gather some of our information, but our job is to get what you have, help you process, map out what you have, and now start working to improve that data. So, but the purpose of this is to improve your processes. And where people keep sliding on this stuff, and I'm not accusing you of doing that, but a lot of time people go, okay, we got this data, and then when we send it to you, it's like, it's not comparative reporting at all. It's about getting the stuff and then helping you actually use the stuff. That's the key point.
Because it's kind of like our providers haven't had input in the CQS that are in that, in the majority EHR. You know, we're working on those things. So it's not.
Sounds like a new discussion. Sounds like what we need to be doing.
Yeah, they're, you know, they're just.
Yeah.
So,
You're not alone.
yeah. So we don't really want to focus on improving on what we already know how to serve as well. So we need work, we need help in moving toward more effective outcome measures, period. And that's what the EHR, pretty much.
You're going to have to find the germane measures. They'll identify, again, we'll meet you where you are. You identify what's going to work, and then we'll help you with that.
And I would just add another comment I heard is, I had a physician tell me, well, we don't want to submit our data because some of our rates are really bad. And
Yeah.
I thought, I mean, my response was, that's good. We want your bad data because you can show more improvement if you're starting.
There's
with
never
lower
been a
rates.
better time to be a crummy performer.
Right. If
This
everybody
is the time. Go ahead, look stupid. This is the time to do it.
If everybody is at 98% of a measure, then we can't show any improvement through our work. So we want your bad data, is what I'm saying. And do it now while you're in a safe environment before there's any payment incentives or penalties that come out of it. But there is no way that CMS can even identify individual providers or attach incentives to this. But it's a safe place to submit your bad data and then work through it. I wasn't saying you have it, I was just adding that people have expressed, we don't want to submit our bad data.
And to clarify, we have good data, so we have good
Yeah.
data. I'm sure we
It's
have.
just bad measures. That's good data, bad measures. And they're like irrelevant measures. And so you got to find something that's going to actually your folks engage.
Yeah.
And that's where I'm saying, you guys figure out what you want to do, and we'll try to figure it out. Other questions on this? Next slide. So this is kind of the last slide on this section, then we'll take a break. But so with regard to using data, and again, I spent some time on this because this is the thing that most of your docs are going to push back and say, no, that's crappy. And this is going to be their biggest stumbling block. So idea number one would be use NASH standards. Don't be clever. This is not about identifying new truth. Okay? This is about execution. We've got enough evidence-based medicine out there that says how to do things. I will tell you, our experience in Iowa is we've done some pretty sophisticated things, and we very quickly learned we could come up with the very best unique measure that's better than everybody else's measure on something, and try to get everybody else across the country to accept something that came out of Iowa or South Dakota. I mean, basically, we're too small, dinky. They don't, they're just our sample size. So basically, what we've decided, and what we're going to try to push with you guys, is we aren't going to worry about developing the latest, newest measures. What we're going to do is we're going to out-execute everybody else. We'll use your definitions, and we're just going to we're not going to sit here and argue about perfection on academic and education stuff. We're just going to out-execute it. So basically, use the national standards, save yourself pain, because if you make, Wisconsin is a perfect example of this. Wisconsin came up with the most very wonderful data set that was like the national data set, but it was more sophisticated. You know what happened? Basically, they got rejected. NQF adopted the NASH data set that was less good because everybody would do it. So basically, go where the money is, okay? Number two, follow the money. And that means basically, what are they going to be paying us to do? We've got PQRS coming down the road, meaningful use, some of this other stuff. Let's teach to the test. Let's work with our providers to make sure that we're preparing them for where things are going. Number three, beware of the reporting burden. You have to be careful that you don't do 15 measures that no one will pay attention to. You have to make sure that you don't have also, you had to hire 7 people to go and abstract charts. Okay, so what you want to do is use whatever you can, use what's available. Can you pull it from charts? Can you pull it from claims data? I don't care where you get the data, but figure out where you're going to get what you have. To have a discussion locally to move things. Okay. The next one is, again, keep it simple, and I would recommend that you identify a set that you think you can manage. And managing it could be physically, can we convene the discussion? Can our organization receive that many measures? You gotta have at least a couple. But whether you do 5 or 7 or 2 or whatever you do, make sure that you don't choke yourself on your data commitment. What's important here is getting the data and establishing the cycle of improvement. You are teaching your organization how to use data to affect change, okay? And then the last piece, the next one is focus on execution. You perfectly described that issue. We got to measure, it doesn't matter. So the whole point is, don't choose something just because you got it and it's crappy. You got to make sure that you're choosing some measures that are actionable. Will it matter to your providers? Will it matter to your patients? Will it matter to your clinics? So make sure that what you choose is going to be something that you can actually do. And then finally, and I've said this probably 5 times here, but having the data is not using the data. Great if you have the data, and we'll send you the reports, but you have got to create the dialogue on site. You got to figure out how you're going to use the data, engage people, establish the culture, move it forward. And this is, it sounds hard, but it's really invigorating. When you establish the meeting and you talk about it and you don't know what to do, but you just kind of start talking about it and things begin to move. And all of a sudden you got everybody in the clinic starting to kind of pull the same wagon. It's a real cool experience. So I'm going to stop there. Questions on data?
So all of our practices have been doing this in the past. Are you going to be giving those satisfaction experience data?
Go back a couple of slides. I thought that was a patient satisfaction. Nope, I guess, I don't know.
We aren't in this specific tool. This is just the capture of the PTN quality measures. It's definitely something you want to be looking at outside of this data set.
Yeah, and then help with that. I mean, Press Gaming is our vendor, and they're, it's helping.
And I guess what I would be thinking is the reason you're here is to transform clinical practice.
Yeah.
You're teaching your clinic new skills to use data to affect change. You're going to have to address patient satisfaction issues first, but I would actually camp on the clinical stuff first and handle the patient. Remember on that pie chart of those different areas that will be driven in that, there's going to be that consistent 10 to 15% on the style with how we do things. That's where a lot of there will be stuff that comes out of there. I don't know if it's going to be populated by Press Gaming or what, but again, I would get them focusing on the clinical things.
And I just want to point out that the last 2 measures are pertinent to specialists. We have a lot of specialists in our network that say, well, what measures apply to me? So at least these 2, the closing the referral loop and just documentation of meds should be part of every.
Yeah, the crazy thing about that particular 374 is it's only direct EHR, and our EHR can't record it. I mean, it's kind of like,
Yeah.
Have you heard of the Folder Research Support?
Yeah, you are. Our mid, we talk about the scattergram.
Yeah.
We're not on it. No, we're not on it. So we've got our PQS measures.
You didn't have the data?
We don't have any attributed data.
Okay.
And so your QRURs for 15 are blank.
Right.
Yeah, so.
Not real usable, huh?
Yeah. And then,
My narrative.
Yeah. I want to camp on what Susan just said, though. We spend a lot of time talking medical home, primary care, and I'm primary care, and I'm beating that drum a lot, but about half of Compass PTN are specialists. So we're very Any other data questions or comments? Well, why don't we take 15 minutes and then we're going to come back for the last